All right, so I'll give everyone a chance to come back in and introduce our next speaker. So I'm happy to say we have Andrew Bledsoe, that is from the Kentucky Health Information Exchange, speaking with us. Andrew is the Deputy Executive Director and State Health IT Coordinator at the Office of Health and Data Analytics and KHIE. The intersection of health information technology with care quality delivery has provided Andrew Bledsoe with a unique perspective over his nearly 17 years in healthcare. Starting his career in a regional hospital, he quickly learned the challenges in healthcare, especially rural medicine, and he began investing in the concept of leveraging health information technology to improve outcomes for patients. His current appointment as State Health IT Coordinator and Deputy Executive Director of the Office of Health and Data Analytics within the Cabinet for Health and Family Services primarily focuses on implementing the Kentucky Health Information Exchange strategic and operational plan, promoting the statewide exchange of patient health information, spearheading a number of new services designed to improve care coordination and offer new avenues to reduce reporting burdens and foster interagency collaboration. So I'm happy to welcome Andrew up.
Thank you, Brent. With the camera and the podium, I feel like this is actually a game show. I was really hoping you would say, "Come on down," and then I could come running in from the back or something. Maybe next time. Okay. Well, let's see. Got the clicker. That's good. Okay. I'm Andrew Bledsoe. That long introduction, unnecessary, but now you know who I am, who I'm with the Cabinet for Health and Family Services. Here today to talk to you about the Kentucky Health Information Exchange. Bridges to coordinating care. I love that, but this presentation has nothing to do with bridges, so don't expect anything there. I'm going to actually take it back to the basics because it has been a while since we've been together. It's been a while since I've got to speak in person, and a lot has changed since the last time that I got to do this. So we're just going to kind of level set, take it back to the basics, and talk about all the new things that we've been working on over the last couple years because we've been very busy. If you don't know, if you've never heard of the Kentucky Health Information Exchange, then I would be surprised. But in case you haven't, we are a health information exchange, both the noun and the verb. We exchange health information electronically, and we are the Kentucky Health Information Exchange. We are based out of the Cabinet for Health and Family Services, which is pretty unique for HIEs across the nation to be wholly owned and operated inside of state government, but offers an extremely valuable benefit to the healthcare community in Kentucky, because what that means is we are able to easily collaborate with other agencies inside the state that's important to you, such as the Department for Public Health, the Office of the Inspector General, Behavioral Health, lots of other agencies. We can collaboratively work together to break down those silos and exchange electronic health information where appropriate on your behalf. Also, it means that we have access to federal funds to offset the expense of operating the Health Information Exchange completely so that we continue to this day to be able to offer our services free of charge. I do like to offer the caveat there that while we do not charge for our services, your EHR vendor may charge for services, such as you will be charged to get the data out of your system, but we're not going to charge you to give the data to us. So that is a benefit and a cost savings to the healthcare community in Kentucky. I like this graphic. This is a new graphic, and I'm trying to learn them, so forgive me if I stumble or mess up on some of my presentation today. But if there's anything that you get from this presentation when we close, is I want you to understand that you can engage with us in two ways. This is engaging with us to push data into the Health Information Exchange. This could be that you are being a good steward of your patient's information. You want to provide it for exchange of information amongst the other care providers in that patient's delivery. And so you push that information to us so that we can make it available to the appropriate outlet. Or maybe you're pushing your public health reporting information. And we'll talk a little more specifically about that. But this is pushing information into the HIE so that it is broadly available or available to the appropriate entity. The second way that you can engage with us is to pull data back towards you. So more than just giving us your information, you can use the information or pull information on patients back to you to help with your care delivery. So we're going to spend most of our time today talking about pulling that data back to you and the new ways that you can do that. Before we do, I want to kind of brag on us a little bit, because I know I myself get in the day-to-day weeds and think we've not done anything. We've not moved the needle at all in healthcare. But really what I have realized in some of our conversations with other HIEs around the nation is we have built one of the most nationally recognized health information exchanges in the nation, and Kentucky should be extremely proud of this. And so I just want to brag a little bit about us so that you have an understanding when you leave here that we can be a valuable resource to you. So we measure ourselves against 2017 data because that was when we launched into a new technology upgrade and implementation. Since then, not only have we added new benefits and features and services to KHIE, but we've also continued to increase the amount of data that's being contributed in. So that increases the amount of data that's available to you coming back out of it. 135% increase in live data feeds, 63% increase in participating organizations. And so, an organization can have multiple data feeds with us. In addition, organizations can have multiple locations that are contributing data to us. And that's where you see the 155% increase in locations sending us data. 100% increase in the individuals in our master patient index. The master patient index is vital to the work that we do because this is how we establish a unique individual within our system. So this means that Andrew Bledsoe, I have one record inside of KHIE, and there's not 3 Andrew Bledsoes, or every organization that's contributing creates multiple Andrew Bledsoes. Our master patient index brings all of them together in that one unique individual, and we have over 9 million lives represented in our master patient index. Now, I'm sure you know we have around 4 million residents in Kentucky. The increase there from 4 to 9 is the work that we do exchanging information with other states. We're connected with all of the contiguous states around Kentucky exchanging data. We are first in number of overall connections for a state-based health information exchange, first in unique patient searchable in the MPI, and second in the number of participating organizations compared nationally. So a lot to be excited about here and to talk through. A few statistics that kind of reflect this. We have 8,300 live connections feeding us data in real time. When data comes into us, everything is kind of normalized into what we call a clinical document. Won't get too technical there, but our repository has 293 million clinical documents available. So when you're querying through those 293 million documents, as well as all of our external agencies who are giving us data in real time. We have we average about 20 million transactions a month. That's 20 million messages that are flowing through our system. Again, that's available to you. We'll talk through that breakdown in just a little bit. And very proud of the work that we've been able to do through the pandemic to support the Department for Public Health and local health departments. We have transmitted nearly 7 million COVID lab test results electronically. That's 7 million lab test results that didn't have to be manually entered into a system by a healthcare facility or manually entered into by the local health department, because we completely facilitated that electronically. So that's been a tremendous support throughout the pandemic. Now, as we kind of transition into the today's KHIE content, I love this slide because, and I think this is actually older than KHIE, it is. And but this shows the types of data that we have access to and that we exchange within the Health Information Exchange. Across the top reflects claims data. Now, it's actually quite remarkable what we've built with claims data over the years. We've built payment processes, payment systems. We've done analytics with it. We've built quality programs, value-based programs. But claims data is only going to tell you so much. It's only going to tell you an encounter occurred. It's only going to tell you that a procedure took place. We map into the electronic health record system, and we capture the data, and it exchanges the data that you have input into the electronic health record system. So we're talking more than just a lab was ordered. We're talking the actual lab test results, vital signs, dictated or transcribed information, lab test results. Once that is entered into your EHR, it's automatically transmitted through KHIE and made available to another agency that needs to see that information. I like to think of that in terms of this iceberg. If you've seen this in any other context, you know with an iceberg, you typically only see 10% of that. Well, we have realized over the years 10% with this claims information, and we now have access to realize the full breadth of the iceberg with this information. So what is this information? I'm going to talk through this pretty quickly, but a little specifically. ADTs stands for Admit Discharge Transfers. This is the most important piece of information that we collect because it establishes the individual in the Master Patient Index, and it also gives us demographic information about that patient, as well as information about an encounter. Essentially, every electronic health record system can send out data in a normalized format, and this ADT is the most common transmitted outward. So the admit, when the admission occurs, whether it be emergency department, hospital, or doctor's office, that message comes out of the system. It says, Andrew Bledsoe, my address, my phone number, my date of birth is being admitted into this facility at this point in time. It's also going to tell you information about that encounter, like clinician information, such as a treating clinician. If you're being discharged, maybe a referring clinician. It's going to give diagnosis information, facility location. We've actually seen that a lot of the hospitals will put in there that, this patient is being transmitted to the third floor of this hospital in room 308. Next of kin information, insurance information. Now those are optional, so not every facility are sending those, but there is a lot of additional and beneficial information in there. Lab results, we're connected to every reference lab in the state of Kentucky, and we're now connected to over 300 commercial labs, again through the work that we've been doing through the pandemic. A large majority of the commercial labs are only sending us COVID information as we've been trying to quickly onboard them, but they are starting to increase those data feeds to include additional information beyond COVID as well. The labs that you're seeing, we are not a results delivery. We do a copy to lab feed, so we get duplicate copies of lab test results that are being completed on your patients. Radiology reports, this is transcribed findings or dictated recommendations of a radiology image. But I'm super excited to announce that just this year, we did a system enhancement and we are now connecting to PACS systems to exchange diagnostic quality images. We'll talk a little bit more about what that means. Other transcribed reports, this can really just be a catch-all. This is what your EHR is capable of capturing and sending electronically. Typically, this is operative reports, emergency department. We have actually seen a lot of history and physicals in there as well. So this is typically information that's been manually input in the system, not in a discrete field. Now, CCDs and summary of care records, that's kind of used synonymous and interchangeably there. This is information about a specific encounter. I like to think of this in terms of if you go to the emergency department, on your way out as a patient, they're going to hand you a stack of papers. Inside that stack of papers lists why you were there, what medicines were prescribed to you, what tests were ran, what labs were ordered, is there any follow-up information, check with your primary care provider. That information electronically is what we're talking about with the summary of care. Now, this is not specific to emergency department discharges, though. Once you have an encounter with a primary care provider, a hospital encounter, everything can create and package that summary of care for that episodic encounter. And we also deliver a longitudinal summary of care out of KHIE, which can give you the full history of a patient. I'll show you that in a minute. Because of our position in the cabinet, we have access to the Medicaid claims data, and so this is, we reflect in our system any paid claim by Medicaid and an MCO, and we reflect that in a readable format. So it's not just a coded value, it actually gives you the information on the medication that was ordered or the encounter that occurred. And we do have a significant amount of public health information available as well. This just kind of breaks down that 20 million that we receive on average a month and what that is. Of course, as I've talked about, ADTs are most important. Tells us the patient, tells us where they're seeking care, but then you can kind of walk around and see labs, radiology, transcription. IHE is CCD exchanges, so that's the number of those summary of cares that we're receiving. VXU stands for immunizations. QBP is an immunization query. Okay, so that's the data that we're exchanging. So in the context of giving us data, your organization or other organizations, this is the data elements that they're giving to us and that we would request for you to give to us because we all want to be good stewards of our patients' information. Now, the way that you can pull this information back to you is through these services right here, and we're going to talk more specifically about them. The most basic and the easiest way to do this is through our ePartner Viewer. This is a web-based portal that we give access to anyone who has an internet connection and the HIPAA authority to view protected health information. You log in, you query for your individual patient, and we do the hard work of going out and collecting all the information from all of their providers, and we present that to you in an easy to review and easy to understand format. What you're seeing here in this picture is the patient summary page. Every data element has its own portlet reflected so that you can quickly see the relevant and recent information, and then you can drill down for more specific information. So like we have labs right there listed. You could click on the lab, see the actual lab report. We now have a graph showing cumulative labs so that you can chart over a period of time one specific lab. Next is our Platinum connection. This is where we are really getting to true interoperability and integration because we are packaging all of the information that we have available to us on your patient and we're delivering it into your EHR system. And so we're not asking you to step outside of your current workflow and go to our web-based portal. We're providing you the data that you need in the system that you are already using. And so this is one of my favorite things to talk about. And it differs depending upon what system you're using. We only package and deliver the information to the door. Your EHR system would have to then pick that up and present it how it would natively present information. I've seen it done in a couple different ways. Sometimes there's a separate tab that you could click into that would pull in that information from outside sources. Some EHR systems are parsing that directly to the medical record. That way you can do medication reconciliation and other clinical reconciliation more easily. Again, that's dependent upon your EHR system. We're just giving it to the EHR to present. Of note, very recently, these facilities here went live sending us summary of care records. Baptist, UK, St. Elizabeth Mercy, Advent, Ohio Health, University of Louisville Physicians. I point this out very specifically because this significantly increased the amount of data that we have available to you that you can receive through a Platinum connection so that you can receive back into your EHR, but as well as through the ePartner Viewer. Any way that you view our information, these organizations' data are now available. So this was a huge feat to get through these organizations and get them onboarded. Event notifications. So the first two that we talked through, the ePartner Viewer and the Platinum, are query-based approaches. That means you have to ask us for information on the patient that you're working with. Event notifications is a proactive approach at delivering information to you. These are the event notifications that we have registered and will proactively send you information on your patients. Hospital admit and discharge, emergency department admit and discharge, hospital readmission within 30 days, behavioral health admit discharge, ED overutilization, which is more than 4 encounters within a rolling 365-day period, specialty visit, positive toxicology screen, lab results ready to review, COVID-19 positive test, and an abnormal A1C. So the way that this works is you first have to tell us what patients you want to track. So you give us your patient panel, and we log that into our system. And anytime that those patients have one of these events occur within our network of 8,300 live connections, we tell you that. We can tell you that in primarily 3 different ways. One is we can send that into the ePartner Viewer portal so that it's available for you when you log in. We have a couple of different ways that we can send that directly into your EHR system so that it's, again, available to you in the system that you're already using. And we can also send that out via direct secure messaging. If you have direct secure messaging embedded with your EHR, that's another way that you can receive that inside of your EHR system. So again, multiple different ways, just depending upon your system capabilities. This has really been the focus of our new technology implementation, is we wanted to create usable services in a manner that is customizable to your technology needs because we know every EHR and every network is set up differently. kind of building upon that proactive approach of information, this is our patient alert query. This is kind of a combination of proactive and querying us. So whereas event notifications, you tell us your patients that you want to track. What about if you have patients coming to you that you don't know information on? So, an easy use case here is emergency departments, or if you have a primary care practice that's open and you receive a lot of new patients, you can set up an electronic query so that there's a trigger inside of your system that sends a question to us every time that trigger occurs. It's commonly set up when you create a new encounter on a patient or you create a new patient chart. It sends automatically in the background that electronic trigger to us that says, Andrew Bledsoe is a new patient here. What information do you know about him? We will send you back answers to these questions right here. Does Andrew Bledsoe have a positive CRE logged or an XDRO so that you would know that you would need to use specific universal precautions with them? Are they currently positive with COVID, or have they previously tested positive with COVID? Do they have a diagnosis of neonatal abstinence syndrome in their past? We do that up until the age of 18. Are they an Office for Children with Special Healthcare Needs patients? Because you need to know up front if they're an OCEAN patient, because you would have to chart differently for OCEAN patients. Do they have a history of abnormal lead levels? So these are the questions that we're going to answer for you. And so this is, again, an electronic way that you can ask us information on specific patients. Next, we have direct secure messaging. And so this is an email messaging system that you can send electronic protected health information across. So this is used in many different ways, and we have lots of different flavors of direct secure message integration. We have a level where we can embed this directly into your EHR system. If you're not currently receiving direct secure messaging in and out of your EHR, we have a standalone portal called Caroline that we can give access to individuals who maybe don't have an EHR system or don't have a very sophisticated EHR system, so that you can still communicate electronically. Kind of the typical use case here is maybe you're a primary care practice and you're working with a home health agency down the road. They don't have an EHR, they don't have an EHR that can communicate electronically. We can provision them access to a direct secure messaging Caroline account, and you can communicate electronically back and forth with them. And so it's kind of the easiest way to think about direct secure messaging is we are seeking to replace the fax machine. I think Brandy's coined term is axe the fax. Let's axe the fax. And so that's what we're trying to do here. We also have a direct catalog that lists all of our known direct secure messaging accounts in there. And I think at last count it was over 6,000 direct secure messaging accounts. That's open for anybody to log their accounts on there. We do ask everyone to kind of routinely keep that up to date as people maybe enter or leave your organization. Next is image exchange. And so this is, again, where we're connecting to PACS systems to gain access to that diagnostic quality image. So what we're going to do with that is primarily we're going to do two things. There are multiple levels of integration here, but the most basic that we're onboarding is you go to our ePartner viewer, our web-based portal, and you query for a patient. We're going to show you the list of all of the available images on that patient there. You can click on that image or that listing, and it would show you a preview quality of that image. Now, maybe that's all you need to see. Maybe you're not interested in seeing a diagnostic quality image. You just want to validate that a test was run and it's available. Or you don't have to hone in on a specific small element of that. So that is available to you, and that's available now. Beyond that, you can actually send that image back into your local PACS unit. So if you log in, maybe you have a patient that's coming to you, or you're working with a patient and they've told you that they've had a x-ray of their elbow. You can log into the ePartner viewer, see that preview quality picture of that elbow, and you think, well, I can't really tell from this. You can click a button, and that goes directly into your PACS system. And so this is extremely new. We are one of the first HIEs in the nation that have this type of a service available. Now, with it being new, we are just starting to build that network. We have 50, let's see, I think we're almost at 60% of the hospitals have committed to providing us this connection into their PACS system. And we're continuing to meet with all of the hospitals as well as radiology and imaging centers to make this as comprehensive as possible. But it takes a while to build that network up. The first hospital to go live is the ARH network. So any of the ARH facilities, all of the ARH facilities, their images are available right now within KHIE, and you can see that. So very exciting what we've been doing. I won't walk through this because I think everyone can kind of understand, everyone in this room at least, why this is important. It's, better security, lower cost, improved safety for the patient. Next is our work that we're doing with social determinants of health. And so this is, again, another nationally recognized collaboration because none of the other states have done this yet. So we have in the state of Kentucky, well, first, we know, the healthcare community now knows that whole care for a patient goes beyond their clinical care. You have to take into account the physical environment, health behaviors, and social and economical factors to treat the whole patient. This is widely becoming accessible or understood in the healthcare community. Within the state of Kentucky, we have a system called Connect Resources. Connect Resources is a social determinants of health platform where facilities can log their resources available that are available to the citizens of Kentucky. So if you have a food bank, if you have a financial assistance program available, if you offer free education, you can log those resources within the Connect Resources platform. It's a standalone platform that you can do that in. Also, citizens can log into that and complete an assessment that will identify what the services they may need to have access to. And then they can get connected with a connector that will help them gain access to that, or can also help them fill out the assessment or fill out the assessment with them. So all of the social determinant of health information is logged on patients and resources inside of Connect Resources. We in KHIE also have large amounts of social determinants of health information. This is provided to us through LOINC and ICD-10 coded information. And so what we do is we take those codes and we have matched that against the 18 priority factors that the state of Kentucky has deemed as high priority. And so we've mapped each one of those codes into those areas, and then we're matching them against a standardized nomenclature here with critical, important, and stable. So based upon the code, based upon the severity of the code, based upon the information you're sending us, we're normalizing that information to the same point that the Connect Resources information is normalizing their data. Because what we're then doing is we're bidirectionally exchanging that. So we're sending our information into Connect Resources, so it automatically creates a profile for that individual. Now the individual has to log in and activate that for security purposes, but once they do, it's then available to them to see that information. Additionally, Connect is sending their assessment information into KHIE, and we're presenting all of this information inside of KHIE through all of the formats that we just talked through in the ePartner Viewer, through our Platinum connection. So we're showing both the micro level, the specific information on that encounter or on that social determinant of health factor, and the macro level, such as how does their housing look against all of the information that's been submitted to this patient. I don't have an image there. And lastly, as we're closing this out, we do a lot of help and facilitation for public health reporting. We do serve as the Public Health Gateway or the Public Health Reporting Authority for Electronic Information, which really all of that just means is that if you are submitting data electronically to the Department for Public Health, you are doing so through a KHIE connection. The beauty of that is reflected here. In other states, you have to connect individually to each one of your public health programs. That is a lot of cost, a lot of resources on your organization to have to not only build but maintain. In Kentucky, you build one connection to KHIE, we identify the data, and send it to the appropriate agency. So this is a real cost savings that you're able to realize there. This is additionally a benefit to public health because we don't have siloed information. This helps you facilitate your meaningful use. You're promoting interoperability measures, does a lot of things. We do a lot of the COVID-19 reporting. We've opened up a lot of new methods that information can be submitted, again, to work with as many different types of technology systems as possible. And we facilitate electronic case reporting, which is also extremely new that we launched this year. Knowing that some facilities are small and aren't able to, maybe they don't have the volume to do an electronic lab connection or case reporting connection, we have a direct data entry option. The beauty of that is you put that information in our system once, we deliver it to the Department for Public Health, we deliver it to the local health department. So nobody, after the time that you input that information, has to manually enter that information into any disease surveillance system. It's automatically transferred. Our KHIE onboarding process, if you're interested in anything you saw here, both giving data or receiving data, when you engage with us, you're going to walk through kind of 3 steps. First is intake. You're going to have a discovery call, intake call, work with our lovely outreach coordinators to go through this process. We'll then migrate you over to the onboarding analysts, the technical team, that'll build the connection, validate your data, and then you're going to go live and we're going to continue to monitor that. This is how engagement looks with KHIE. If you have any questions, please feel free to reach out to Ann, Teresa, or Tiffany, all of which are here and happy to help you. If you have any questions on any of our services, or if you're just looking for a good conversation, they're a lot of fun. I encourage you to go get to know them and talk with them. We've done a lot of work on our website to make it current and reflect as much information that's beneficial to you as possible, so additionally, please check that out as well. Okay. Woo. I only took up, Brent, the time that you delayed me, so.
Thank you, Andrew. Yeah, he saw me walk in the back, and he was like, "Oh, I got to go. It's time to get on this." We're at lunch now, so lunch is set up in the back there. So we'll start back again at 12:30, and so go ahead and join the line and make your way through. We appreciate it.